He's a clinical associate professor for the orthopedic surgery at Thomas Jefferson University. And overall, he specializes in sports medicine surgeries, including ACL, shoulder instability, rotator cuff repairs, and also hip arthroscopy, which he's going to take the floor and discuss all the types of injuries related to that.
Sure. Thanks.
Thank you, guys. I'll try not to bore you, and thank you so much for having me out here. So I want to thank the people at Breakthrough for having me out tonight to give this talk. See some faces that I've known for years, some new faces. We're going to kind of just go over some general stuff about hip and groin anatomy, injuries, common things we would see, and then at the end we can kind of go through treatment. But we can keep it interactive too. If anybody has anything they want to ask, just just shout out. And it's a small room. We can just keep it very informal. Hip injuries have been on the rise in the press probably for the last 10 years, and I think some of that is because not necessarily that they're more frequent, but that our recognition is better. And we've seen it obviously in the press. You're going to see it in high-profile Major League Baseball, NFL, NHL. They're all on the rise. And some high-profile guys who have had hip injuries that have returned to their sports. One of them is a very good, excellent, perennial all-star baseball player, and the other guy's going to jail. For some of you with some more gray hair, you may remember one of the first high-profile hip injuries, Bo Jackson. Anybody who's never seen Bo Jackson play or seen anything, just go ahead and YouTube it and watch some of the stuff this guy used to do. Bo Jackson was a two professional sport athlete. He was so good that when he was done playing baseball at an all-star level, he decided he would just go play football for the Oakland Raiders in the middle of the year. Without training camp, without anything, he would go pick it up and then dominate the league. Unfortunately, he dislocated his hip on a tackle and ended up with avascular necrosis, and that pretty much ended his career. We're going to go through some of the things about the arthroscopic treatment of the hip. This talk is kind of a mishmash all over the place, but what we're going to talk about first, if I can get to it, is some of the anatomy around the hip. But when people have injuries around the hip, traditionally they were treated non-surgically. Most injuries are still able to be treated successfully non-surgically, but with our technology now, we can treat most of the problems arthroscopically. 15, 20 years ago, most things needed to be treated open. Now, open sounds like, ooh, it's ancient. It's actually the proper thing for some, even today with some of the injuries and pathology around the hip. So some of the challenges for certain surgeons and my colleagues who do this on a day in, day out basis are not only figuring out who is appropriate to have something done, but what kind of procedure needs to be done. Can they be fixed arthroscopically if they need to be fixed? Or should it be done open, or should it be done combined? Or should they not have surgery? There is a tremendous learning curve that we have to go through for these kind of procedures. Some of this is technical that we're not going to go through, but what we see that's very good is the complication rates with all these procedures is very low. So that's what we look for when we're doing any kind of procedures. Shoulder procedures, ACLs, when we're doing rotator cuff repairs, everything done. With shoulders, rotator cuff repairs, shoulder dislocations, they're all treated arthroscopically now. It's a standard of care. In the 80s, that was voodoo. It was like, what are you doing with this? You're sticking a camera inside a shoulder? Were you crazy? Everything was done open. Big incisions, go in, see it, try to fix it. The knee, that backs up to the 70s when arthroscopy started with that. With the hip, it's kind of one of the last frontiers. We're in the middle of that right now. 10 years ago, we used to get yelled at in our national meetings, like, you guys are out of your minds. What are you doing to patients? And now they're like, oh, well, how are you doing that? So the complication rates are low and our results are very good. But when we're evaluating hip pain, first thing we're thinking about is you have to have the knowledge of the anatomy around the hip. The bones, the soft tissue structures, neurovascular structures, and the muscles. And when we have somebody come in with a problem, we want to take a good history. 90% of the issue can be picked out in history. Focus history, figuring out where's your pain, when's it happening, what are you doing when it's happening, what have you done to make it better, what are you doing that makes it worse. Physical exam, we can go through a couple little things, and then we always get x-rays to start, just because we can't see bones unless we have those Superman glasses on. And so we need x-rays to make sure the bones are okay, and then there's other studies such as MRI and CAT scans. So when we're talking about the anatomy of the hip is a highly constrained ball and socket joint. So the ball comes from the thigh bone, socket comes from the pelvis. Sounds like a very simple joint, but it's actually very delicate and intricate how it works. But if you take all the soft tissues away from the hip, it's inherently stable. So the bone, the ball is going to stay inside the socket. If you look at a joint like the shoulder, if you take all the soft tissues away, it's going to fall apart. So the shoulder needs all the soft tissues to stay stable. The hip stays stable by itself as far as staying located. But we always want to know about the soft tissues around the capsule, the ligaments. The labrum is the structure we're going to be talking about, and then there's a ligament deep inside the hip. So this picture kind of shows with the hip pulled out. The ball comes from the thigh bone, and that's the femur. The socket comes from the pelvis, and that's the acetabulum. So there'll be a quiz on the way out. You guys can't have any more wine. And the labrum, which is an important structure to talk about, is actually on the pelvis side. It forms almost a C around on the acetabulum. So the ball sits right inside the socket. The labrum helps with the stability and the congruency, or the roundness of the joint. The ligaments are actually the strongest ligaments in our body. And the ligaments are actually outpouches of the capsule, the soft tissue covering that's around every joint. There's a round ligament in the middle of the hip called the ligamentum teres that provides some rotational stability. And then the labrum really deepens that socket and allows that ball to kind of sink in and rotate around. The labrum is the usual suspect in people who have hip and groin pain if there is a structural tear. It's made up of a special kind of cartilage, fibrocartilage. It's different from the cartilage cap on the end of the bone, which is articular cartilage. So there's two different kinds of cartilage in the same joint. So it's pliable. Again, it looks like a C when you take the ball out of the socket, and it lives around the entire acetabulum or the pelvis. This is a picture arthroscopically actually of a tear, a little probe here, so the stuff looks like crab meat is a tear. So crab meat's great at a buffet, it's not great inside a joint. This is just a little cutout slide. This little black stuff is actually dye, so somebody who needs a new hobby went in and took a cadaver or a donated body and got the artery and injected dye into it just to show where the blood supply goes. But it makes a great picture. The reason that's important, anything we fix in orthopedics, if it doesn't have a blood supply, it's not going to heal. If we fix it back and it has a blood supply, it's going to heal. So that's why knowing where the blood supply is important and critical. What the labrum does is it really just makes a seal around that head. So the ball comes into the socket. If the labrum's not there, it kind of rotates around, slides around. If the labrum's there, it kind of sucks it in. So it really just traps all that good synovial fluid, or the fluid of the joint, inside. It makes a perfect environment for the articular cartilage to live. That's critical because we're only born with one set of articular cartilage. You don't get another one. So when that starts getting damaged, it's an issue. A normal hip has about a 140-degree arc of flexion extension overall. You don't really use very much of it, only about 40 degrees when you're jogging, obviously more with full-out sprinting. But your arc of motion is pretty limited. Now a shoulder is about 180 degrees, a knee is about 145, so it's a little less than both of those. And then the rotational stability, the rotational arc of motion really depends on the patient and the way their bones are lined up. The hip and groin injuries are much less frequent than those in the knee and the ankle. So you guys who are athletic trainers and physical therapists, you guys know, most of the stuff you see coming in, knee injuries, ankle injuries, shoulder probably follows that, low back injuries, and neck strains. Then you get down into, if you're dealing with high school athletics, your next section is going to be hip and groin injuries. It's about 5 to 9% of all the injuries that come into an athletic trainer during the year. So it's a lower percentage. Now those numbers are actually from about 5 years ago. And when they redo this, I bet it's going to be higher, just a higher percentage, because I think we're recognizing them more. Like any injury, rehab and recovery is significant. So we want to make sure we recognize the injury, treat it, get them back, especially when we're dealing with athletes. So what causes hip pain? A lot of things. Depends if we're talking about a 16-year-old athlete or a 50-year-old young athlete. Arthritis, by far, if you look at everybody, is number one. It's the number one problem. You're dealing with people from 16 to 70, 80 years old. Arthritis is the number one cause of hip pain. Unfortunately, arthritis can happen in people who are even in their 20s. So that's the most common cause. Labral tears, tears of that cartilage inside the hip, is probably number 2. After that, we were dealing with labral tears of something called impingement. We'll just call it FAI. I'll go through that because that's critical, especially for young people, pre-arthritic people with hip pain. Muscle strains, they happen. True groin strain does happen. Avulsions or apophyseal injury, so that's a tear of where the muscle and tendon comes into the hip bone before patients are fully skeletally mature. So they can pull off a little fleck of bone, pull off a little fleck of the tendon. Snapping hip is a tendon issue, and then hip dislocations, fractures, we're not really going to talk about today. So with all these kind of injuries and all these kind of different problems, in my mind, this is how we kind of break things down when people are coming in, we're evaluating them, talking to them, finding out where's the problem, what are we doing, how are we going to treat this. So when I break it down to problems that are intra-articular, or mean inside the joint. Extra-articular means just outside the joint, or what we call hip mimickers. So inside the joint are the structures that live inside the joint. Labrum, the cartilage, loose bodies, so people can form loose pieces of cartilage or bone that can be in the hip, and they can cause catching, locking up of the hip. Instability, ligament tears, stress fractures, and then damage to the articular cartilage. That's most of the list from inside the hip. Extra-articular, just outside the hip, so athletic pubalgia, also known as sports hernia, also known as core muscle injury, also known as Gilmore's groin. It changes every 5 years. It's going to be core muscle injury from here on out, trust me. I worked with the national and international guru who made up the term sports hernia, hated it from the day he said it on ESPN, has been trying to change it forever, and finally, at least the orthopedic community is changing it. But that's really a muscular issue. We're going to talk a little bit about that as well. Your IT band on the outside part of the hip, common problem in runners, common problem in dancers. Tendons around the hip, bursitis, adductor strains, so that's the muscle on the inside of the hip. So they can all cause problems and pain around the hip. Mimickers, low back pain. A herniated disc in the back can refer pain to your hip. Hurts out here, the problem's up here. Sports hernia and athletic pubalgia kind of go to both sides, and then a breakdown at the middle of your pelvis is osteitis pubis. So that's kind of the categories we're trying to break down, because we have to figure out, by the time they get to me, when you guys are seeing them, you're evaluating them right off the field, you're evaluating them acutely, you're going more towards the muscle strains and possible true tears or other pathological problems, but you're figuring them out right there. By the time they come into me, they've seen you guys. They've been evaluated, been treated properly. The non-operative stuff, the initial stuff of activity modifications, anti-inflammatories, all that other stuff hasn't worked. So that's when the phone call comes, yours. Figure it out. So by the time I get them, I'm kind of going through those categories of figuring out what's going on. Tears in the labrum. That's probably the #1 reason that I see people with hip pain. Now that happens for many reasons. It doesn't just happen by itself. It's usually not a traumatic traumatic problem. An ACL tear has a gotcha moment. Somebody's going out, they plant, cut, turn, twist, pop, swell, they tore their ACL. That's not the way the labrum is with the hip. It's a buildup over time. It's more like an attritional problem. And it's usually due to some malformation with the way everything's shaped. #1 problem would be impingement, which I'm going to go over in a minute. #2 problem would be dysplasia. So impingement is a really tight hip, dysplasia is a wide open and loose hip. And then subluxation or instability of the hip can cause it as well. What FAI is, impingement, we're going to make this easy. So a normal hip is up here on the right. Normal shape of the hip. Again, ball, socket, nice and concave here. What I tell my patients is, it looks like ice cream on an ice cream cone. Fat head, thin neck, that's the way it should look. And what impingement is, it's a malformation of the way the bones are formed. So that instead of coming down like this, the bone's bumped out like this. All right? So when they flex up their hip and rotate it, it starts crushing against this little labrum here. So you have a bony sandwich with bone on both sides and a little labrum inside trying to live. It doesn't work forever. That's usually why the labrum tears. That's the #1 reason. So the cam comes from the thigh bone side. The pincer comes from the cup. Instead of the cup being like this, the cup is very over-constrained, so it looks like a crab claw. That's why it's called pincer. We're simple people who eat small meat for things, so we remember them. But most of them are actually mixed. They have a little combination of both issues. And what we see on our x-rays It's a little hard to see. This is before surgery. So this is that little bump on the outside. So it's going the wrong way. You can kind of see the shadow of the normal part here. But this whole bump's going the wrong way. And this is after surgery with this patient that we went down and reshaped it so it's nice and smooth. So it looks like ice cream on an ice cream cone again. So when we go in there, we have to take care of not only the labrum and the soft tissue problems, we have to take care of the underlying issue, the impingement. If we don't take care of the bone, it's going to happen again. This one you can probably see it a little easier. The bump's going this way, and that's the same patient, and this is the one after surgery, so now it's coming back down. So we got that bone out of there, and after we fix this patient's labrum, we get rid of that bone, so it's not going to happen again. So the impingement is an important problem, and that's usually the #1 cause for labral tears. Patients usually don't have a history, again, of a gotcha moment. It's gradual buildup. They have hip and groin pains deep in, they can't put their finger on it, and it just gradually builds up over time, and then they start changing their activities, modifying the way they're doing things, and then eventually the pain starts getting into daily activities and it goes downhill from there. Usually it's groin pain or pain deep in the front of the hip. Sometimes it can go to the outside part of the hip, sometimes to the back, but most times it's concentrated more towards the front and deep in. And again, they can't put their finger on it. They can't say, okay, this hurts when I push right here. Because you got 2 or 3 layers of muscle till you get down to the joint and down to the problem. They can have limitations of motion, especially sitting and with rotational activities. One of the other issues we see, and Dr. Myers would kill me for still having this slide up here. So we'll call it sports hernia for now because everybody knows what that is. So it's a horrible term because it's not a hernia. And the only thing good about it is it says sports, and that's the second word in ESPN. It's actually a tear of the muscles. So it's a tear of your abdominal muscle where it comes down right on your pelvis, and also your groin muscle. They meet on 2 different bumps on the pelvis right here. So it's pain towards the front of the hip. Again, tears in the labrum or problems inside the hip joint, usually pain right in here. So there's a lot of crossover between the 2 pathologies when we're trying to evaluate the patient. And to throw another monkey wrench in it, a lot of patients have both problems. They can have a tear in the labrum and impingement and a sports hernia or core muscle injury. The key with the sports hernia is its pain. That is their #1 problem. It's not a structural issue. They don't have arthritis. They don't have fractures. It is pain, and it's activity-related pain. And it's always concentrated right up in the front. But when we're picking apart their symptoms, it's usually more when they're firing their core. It's when they're doing abdominal work. It's still when they're pivoting, but it's more because they're planting and turning. They're firing their core to try to stabilize their hip when they're changing directions. And that muscle is torn. So when it's torn, it hurts. And this is an area when this tendon tears, it doesn't heal. So it continues to be painful. They get treatments, it gets better. A few months later, they get back to sports, it hurts again, comes back, and it's a vicious cycle that keeps going. Long term, it doesn't cause any problems for them other than pain. Once we try to figure out in the history, which kind of gives us everything, 90% of what we're looking for, we can kind of figure it out. Then we do a physical exam. First thing we look at is how they walk. So watch them walk across the clinic. Do they have a limp? Do they shorten their stride? You know, people think I'm just staring at them. I'm like, no, I'm watching you walk. Never mind. That's in Cohen's class. So we're watching them to see if they have a hitch in their gait, see if they have weakness. Do they have evidence of a tendon? If your tendons are weak over here, you can't pull your leg out to clear around, so you tend to lurch, to swing your leg around. And there's all kinds of things we can pick out just by watching people walk for 15 feet. We also then palpate for any tender areas. So we're looking for any tender bony prominences, tendons, things like that. And then we check their motion, check their strength, check their stability. And we can usually pick out where the problem is. If it's a muscular problem, you're going to be able to figure it out with an active test. If it's a structural problem, then it's usually more of a passive test, which means your examiner, your physician, your athletic trainer, physical therapist have to move you and manipulate you to reproduce the symptoms. Our key is we want to reproduce their symptoms with a specific maneuver to figure out where the problem is. If it's a labral tear, typically they're going to start having pain when they flex up higher than 90 degrees. Because that ball is rotating up, and it's going to start pressing against the labrum, and that's going to start getting them uncomfortable. You start feeling an ache when they come straight up. And then when you rotate them, that's when it hurts. And that's going to be like, yeah, that's the problem. That usually guides us to a tear in the front and the front outer corner, or the anterior anterolateral part of the labrum. The posterior labrum usually is not torn, which is interesting because that area actually takes a lot of stress. But usually the labrum is different in the back than it is in the front. Most of the tears are up around the front, which is why most of the symptoms are up around the front. With impingement, we're trying to figure out, haven't seen x-rays yet, but trying to figure out, is this person tight or are they loose? So people with impingement, if you can picture that schematic slide with that bony bump going the wrong way. If you have a bump, you can't stretch bone. So as they come up and as you start engaging that, if they have a big bump, actually as you flex them up, they're going to start rotating their hip out because they can't, the bone's rubbing right against the cup and you're going bone against bone, you can't do it. And if you try to get them even to neutral, they're going to start hurting. If you go this way, your exam's done because you're really going to hurt them and they're going to say stop. So if they have significant impingement, we can pick that up just with a little passive flexion up. If their foot starts rotating out, and you start thinking, we need to see this x-ray because there may be a big bump of bone there. But people with impingement usually have some decreased motion, even though they may have impingement on both sides. Usually the more affected side is going to be inflamed, so it's not going to move as smoothly. And that's a key to look for is once you get over 90 degrees, if they start really losing their rotation, you got to think that there's something going on either with the labrum impingement or both. Now, just to completely confuse you guys, when you do those same maneuvers, if they have a hip flexor strain, it can give you the same symptoms. All right? This is why this is all fun. So as you flex up, because the hip flexor tendon runs right up in the front, then you're bringing that up, but again, even passively that will hurt. Difference between impingement and a hip flexor, just do a straight leg raise. Simple straight leg raise. After you examine them and it have irritated the tendon, that's still going to hurt them. With impingement, it may not necessarily hurt anymore because you're not passively cranking. So with hip flexor tendonitis, you have to get that tendon to fire, and that's going to reproduce their symptoms. With impingement, you have to move it in order to get it really cranking. One of the other things we look at is when we ask patients, this is really more for their history of where their pain is located. And again, like I said before, they can't feel it, they can't push on it, so they kind of make us see with their hands, like, well, it's kind of here, or if I could put my fingers together inside my hip, it's right there. Guys, it's probably in deep. There's all other kinds of muscles and all other kinds of tests. Is again going through that other slide of the 3 columns of things I'm looking for is what's wrong with this patient, why are they here, how can I get them out of my office? But really just trying to figure out what's going on with them and how are we going to get them better. We have to really figure out what the problem is before we can get it better. X-rays are the first things we look at. I didn't put any X-rays in this talk to bore you guys. But there are a lot of things we can look at from an X-ray. First thing I'm looking for is arthritis, and you can see that on an X-ray with loss of the joint space. Next thing I'm looking for is the alignment and impingement, and we get certain angles of our X-rays. It's not because I like to torture patients, but it's to try to get the X-ray beam shows you right on 90, parallel to where the beam is. That's what problem you're going to see. So we have to get in certain positions to get that X-ray beam to really catch that impingement at its worst spot so we can really evaluate how bad it is. So I got a good set of weight-bearing X-rays for everybody when they come in. Most patients come in already haven't had an MRI. Most of them are getting an arthrogram, which means an injection of dye. It just gives a little better contrast when we're looking at the hip. And this is a normal MRI over on this side. The white stuff is just the dye. Here's your ball. There's your socket. The labrum is this nice little black triangle here, good signal throughout it. This is a different MRI. It's got a positive arrow sign. All right, so that's usually pretty good for us because that means radiologists is saying, look here. This is, I drive them nuts because I've figured out on most of the radiology sites, I can get on there with a mouse and move this arrow around. So it drives them crazy. But we see the dye coming right under here. This is the labrum. and then the dye is coming right under. So this tear is completely off of the pelvis. And then this next one probably shows it a little better too. So this is a hip looking from the side. This is the front, this is the back. That's the labrum. It's supposed to be firmly attached over here, so you're not supposed to see this fluid come under it. So this is a pretty big tear. Same patient looking at a different angle. You can see the white again coming down right around here. All this white is injected fluid. It's contrast, so it looks white when everything else looks dark. And this is just a capsule around the hip. But those are some good, MRI is a great tool because it can really show us in detail the labrum, the cartilage, the soft tissues, the tendons, everything around the hip. But we have to be very critical about our studies too to make sure that we know what we're dealing with. And no offense to anybody who's related to any radiologists, but I trust no one to doubt everything. That's why most of us have learned a long time ago to read our own films. And like anything in life, there's all kinds of different quality of stuff that comes through. There are MRIs that come through and I'm looking at them like, what is that? And then there are high quality MRIs that give me too much information. It's almost like information overload. But you have to learn to read it, and I really try not to look at the studies until I've talked to the patient. So I have an idea of what I'm looking for, and then go confirm it. So as far as treatment, let's say theoretically we actually figured out what's going on. How do we get them better? Most things, initially conservative treatment, rehab, activity modifications, anti-inflammatories, do everything we can to try to get them back, get their symptoms gone, get them safely back. Modifying activities is always a fun one with an athlete because they never want to stop. They want to say, okay, 3 weeks, I'll shut down, but then I want to be back. If I'm not, then you do something. And sometimes, actually most times, the right thing to do is to shut them down. And it's going to lead to an argument, it's going to lead to tears, but you have to do the right thing. Most of these things are going to get better with time. And they may not need to be treated surgically or even with anything like a cortisone injection. They may just need some therapy. They may be doing things that they don't even realize they're doing. And then when they're evaluated by a professional, by the athletic trainers in school, with a physical therapist at a place like this, they can pick it out and say, look at the way you're running, the way your heel's going down, you're rotating out like this, and it's something that can be corrected and the pain goes away. That's the first thing we always try. When all that fails, then we're dealing with surgical issues. The hip surgery that I do is really all arthroscopic. So it's just small incisions, fiber optic camera. With that, we can see everything inside the joint. You know from your meniscus surgery, you know, it's the same idea. In the shoulder, same idea. In the hip, same idea. The difference with the hip, it is an unforgiving environment. Right? It's a very constrained joint. Whereas the shoulder, we can move anywhere. The knee, we can put a scope in, we can go anywhere we want to go just by kind of rotating the knee around. With the hip, it's not going anywhere. You got to move it. So we have to have these special tables to pull some distraction in that joint, so that joint really sits in. So we have to pull traction on the hip of about 3/4 of an inch in order to safely get our instruments in there and get around and do work and not do damage and do the work we want to do. So there is a pretty high learning curve, pretty steep learning curve to these procedures. Most people coming out of their residencies right now and their fellowships, they get a ton of shoulder exposure, they get a ton of knee exposure. They're really highly skilled when they're coming out of training. Very few are getting repetitive exposure to the hip procedures. Most of them are actually that want to do it are then going on to spend extra time with somebody who does a lot of these procedures. It really is a significant learning curve to it from our standpoint. And we respect the learning curve because a learning curve means not good outcomes, right? That means you could be doing damage when you're going in. So some wise Greeks said a long time ago, first do no harm. And that's what we always try to do. So it's a technically demanding procedure, but it's an excellent procedure for intra-articular problems in young patients and pre-arthritic patients. I will say this, and you will always hear me say this. If you have arthritis in your hip, you do not need an arthroscope anywhere near you. We learned our lesson from the knee. It's the same thing. If you have arthritis in your knee, that is not the proper treatment. What will happen is you'll feel good for a little while, and in 3 to 6 months, you'll be right back where you were, or worse. So arthritis is the #1 contraindication for a hip arthroscopy. But for most of the things that we're dealing with in pre-arthritic people, so they haven't developed arthritis yet, or athletes, when they fail everything else, they're excellent techniques to repair the labrum, remove loose bodies, take care of the impingement, and shave down that bone and take care of all their issues. Tendon issues we can take care of as well. The complication rate, very low. We're talking about 1 to 2% of all comers that can have complications from this. Injuries to the cartilage, probably #1. That's when people sticking the scope in there, right? Injuries to nerves usually is either from positioning because of the traction we have to do, or it can be from loss of sensation on the outside part of the hip. 95 to 99% of the people who get those, it completely resolves on its own. So these are the kind of complications you want. It's a very low complication rate, and most of them will get better. Stiffness, it can happen after the surgery. Usually that's due to not really moving quickly enough. Blood clots are very low, about 1 to 2%. Fracture is extremely low, but fractures can happen because where we're resecting that bone and we make a little weak area. So if you go out and start pounding on it right away, you're going through an area that's doesn't have the same structure it did, 90 minutes before, and you can fracture through it. That can be a devastating injury in a young patient. This is just a picture of a patient in the operating room. Head's up here, foot's down there, so everything's all draped out. But these are the little, what we call portals. So portals just mean we make the incision in the skin, put our instruments through here. So this is the outside part of the hip, their pelvis is up here. Usually it's 3 portals, 3 small incisions, and we go in and can do all kinds of work in there. Take care of the impingement, take care of their labral problems, their cartilage problems. When I said before we had to distract the joint, so this is probably the best one to see it. We stick a little needle in the joint, we put everything over a flexible guide pin, and then we get this little space in there. That's the space we have to work. Our cameras are only about 5 millimeters in diameter, so they're pretty small, and our instruments are about the same. So with that little bit of space, we can kind of get in there and manipulate our way around. But like anything, it's easy to mess it up. So I came up with this, how to mess up a hip in 10 easy steps. #1 is patient selection, by far. The other things are, a lot of these are more technical things for surgeons that we're teaching how to do this stuff. I'm not really going to get into those, but we'll go through a couple of these just because mainly I love this next picture because that's my clinic. All right? Patient selection. These guys are not likely to listen to you. All right? You go do whatever you want to them. They are not going to listen to what you say. He's got 2 teeth. Right? He is not going to listen to you. Now, the scariest thing about this is whatever this guy's going to do to these two once this picture's over. That guy looks scary. But patient selection is important. We want to be realistic with a patient. First of all, their expectations for the outcome of any procedure. Right? I sit down and talk to them and say, look, this is what's wrong with you. This is what we can do. This is what is likely to happen, and here are your timelines. So the patient has to be realistic, the surgeon has to be realistic with what he can do, what he can't do. What can I likely help, what may not get better, and what are the risks? Arthritis, again, I'll say it, and just it doesn't work. It makes people worse. You don't scope people with arthritis. Dysplasia, that is the other side of impingement. So whereas impingement is a tight joint, dysplasia is actually when the cup is wide open. So it's like a very lazy C. And that can cause all kinds of instability issues. Eventually, these patients do tear the labrum, do tear the cartilage. But if they have significant dysplasia and you do an arthroscopy on them, it will fail and it will cause an issue, including their hip dislocating and them getting a total hip. So I'm very, very cautious about that as well. It's really, that's a bony problem that you can't do a soft tissue procedure to cure. So there are other things to do for people who have dysplasia, but the arthroscopy is not the only thing you can do. Positioning, we don't have to talk about. That's just the way the leg looks. This is the distraction device we were talking about in the operating room. So it's just the patient's asleep. They're comfortable. They're But this is a little traction device and a nice big pad. This thing looks like, anybody remember American Gladiators? The big padded things? It's exactly what that thing looks like. It is foam and it is that wide. So it really just pads it well, but it gives enough, of a post around here that we can just pull the distraction we need in the hip, and we minimize the time that people are in traction. We really try to keep that to a minimum, because the longer you're in traction you're pulling, the more likely you're going to have some issues. So we really minimize that, and we go in, do our work that we need to distract, get the joint distracted. And as soon as we're done with that, let the joint relax, let everything relax. When we go shave down the bone, that's not on traction. So when we're on traction, we're taking care of the labrum, taking care of the cartilage, all the stuff inside the joint proper, and then we let the traction off, and then we can take care of the impingement in the bone with the traction off, because they're safe when we have time. You don't need to know this, but the cartilage injuries can happen. So cartilage should be pearly white. That is an actual labral tear, all that crab meat. And this is a revision surgery that I had done. And this is a little signature left by the previous surgeon. The cartilage here was just where that portal came in, and it kind of just came into the cartilage a little bit. Doesn't cause any long-term problem, but it's not ideal. It's not what we want. We don't need to talk about that. Are you guys planning on doing any hip scopes soon? We won't talk about that part. What can we do in there? With the labrum, we can debride it if it's a tear that needs to be trimmed. That's what debridement means. Most of them we try to repair. The outcomes of patients do much better when we repair the labrum versus the same patients when we trim it. But there are certain tears that you can't repair, because again, it all goes back to the blood supply. The labrum's like a triangle. The blood supply comes from the base. If it's torn on the inside part of the labrum, there's no blood supply there. We have to trim it. If it's torn at the base, there's blood supply. We do everything we can to repair it. And in some patients who fail repair, sometimes we go back and reconstruct it, which means make a new one. But if general things in the hip arthroscopy are new, that is super new. But the results look pretty good so far. With the impingement, again, we go take care of the bone and make sure that the impingement is out of there. There's other places that we can go in and around the hip. The bursa around the IT band, people who have snapping hips, so their tendons pop up over the bony prominence. Actually, it's pretty simple to go in there arthroscopically and lengthen that tendon, gets rid of the snap. Works very well. Post-op complications are rare, they're low percentage. Nerve injuries, infection. I've done over 1,000 of these procedures. I've had one wound infection. Just the wound right here, never in the joint, never anywhere else, just one wound infection. Doesn't mean more won't happen, but the infection rate is extremely low. Nerve injuries very low. Pain's a tough one, because if you go in there and fix all the structures, you take 100 patients with all the same problem, and you fix them all, and they all heal, you're not going to have 100 patients that are happy. Some people still have some pain. So that I put that down as a post-op complication, because when patients have pain, I feel like I didn't do my job. Blood clot we talked about, and fracture we talked about. But in summary, hip pain it's a common thing we're dealing with. It's definitely being recognized more. I think that's why we're seeing higher frequency of things. We're more tuned into it. Our radiological studies are that much better. We can pick out the structures, but we also know how to treat them and how to get them better. We know what we've done that's made them better. We know what we've done that hasn't worked, and we don't do that anymore. And that's how we learn things. We really take a critical look at outcomes of all our procedures. The thorough history and physical exam is critical. Younger patients, we're thinking more problems with the cartilage, the labrum, impingement, or dysplasia. Older patients are thinking of arthritis. Again, impingement and cartilage injuries, but mainly arthritis. Arthritis is not dooming. And people who have arthritis, if they need a surgical procedure, the surgical procedure they get is a hip replacement. It is the best procedure we have ever invented in orthopedics, period. This goes back to the 60s, when the implants looked like, I don't know, something from medieval times. They went in, put them in, they lasted for 20 years without pain. So the backup for people who have arthritis in their hip, you're not doomed. If it comes down to everything else is failing and you're still having pain, you're still having major problems, and you need surgery, it's a great surgery to fall back on. But it's the proper surgery to fall back on for arthritis. Imaging for us is critical. I'm very critical about my x-rays, about my MRIs. and making sure that I can see what I want to see, that I get the proper images. The more accurate it is, the better we are going to be at picking out what's wrong so we can get it better. So again, no offense to any of you who've been in my office, my goal is to get you better so I can break up with you and you can move on with your life. I don't want to date you forever. I already have that. She's at home with my 2 kids right now. So these are actually just, they're little videos showing, that's just one of the anchors going in around the labrum. The videos aren't moved up. And that's one of the sutures. So the anchors have sutures in them. The anchors go in the bone. So anybody who's put in wall anchors, all right, it's the same idea, but ours are much better than the ones at Home Depot, and much more expensive. So they kind of go, you can't really see it, kind of goes into the bone. These 2 things are sutures that are embedded in the anchors. The anchor goes right into the bone. We pass the suture around the labrum and tie knots back down. It's basically glorified fisherman's knots. And that's what we want to see. We want to tie this thing back down so it is restabilized. The ball is here. The labrum's here, fixed back. All the knots are away from the joint. So when this ball comes into the joint, they won't even know the knots are there. And then we just let it heal, because if it has blood supply, it heals. And that's all I got. How'd I do?
Fires, why nothing?
This is your time. Yeah.
How successful is the microfracture surgery?
Microfracture is a tough one because that goes to treating the articular cartilage. With the labrum and labral tears and impingement surgery, it's about 85% of the patients get good to excellent results, which means no pain or very little pain, but no significant limitations. They can basically do what they want to do. 10% are good, so they're improved from what they were doing before surgery, but still have some limitations. 5% can get worse. You throw in a microfracture, all those numbers are going to drop. The thing about microfracture, it's one of the few reliable weapons we have, but it's like bringing a knife to a gunfight. I mean, it'll work okay, but we're waiting to invent the gun, basically. The whole idea of a microfracture is to tap into your own stem cells. So on the articular cartilage, which is the cartilage cap on the end of the bone, when you lose that, that's devastating. You're born with one set of that, you don't get another one, and there are very few ways to effectively create new cartilage. The microfracture, what we do is drill holes right into the bone, because the cartilage is gone, you're down the bone, you're staring at it. And we tap into the stem cells in the pelvis, and that grows into there, it bleeds into there, but then that clot can eventually mature into a fibrocartilage. So it's kind of like a cartilage patch. It's not as good as your normal cartilage you're born with, but it's better than nothing. The success of it really depends on the size of the defect, how old the patient is, and what else is going on with their alignment. So there's a lot of factors involved, but most of them are on the acetabulum, the cup side. I would give them about a 70 to 75% of good to excellent, and then everything else goes to good. And if it's on the femoral side, it's probably less, because it's just a different animal. That looks like a personal grin. That's a tough one. But as long as their impingement is treated and the other problems are treated, the microfracture is a good adjunct. Going in there and doing a microfracture alone, but not taking care of an impingement, that's not going to help them.
I'm not sure if there's impingement. I think it was like necrosis and.
Avascular necrosis is a different animal. Yeah.
Never mind. He got it done. I'm like, I don't think that's going to work. So
well, yeah, but the other thing is, you can't do nothing.
Yeah.
You know, it's going to give them a chance. I mean, 70% is better than 0. So it gives them a chance, but it takes time. They have to be non-weight bearing for 8 weeks. It's going to take months and months to get the motion and strength all the way back. And we don't judge it till 6 months or a year from surgery. So you can't really judge it. We don't judge it with an MRI. It's a common question. We're like, why don't you get an MRI and see it? It's like, it's going to show it's normal.
You have to do surgery again?
No. Talk to him. Examine him. See how his symptoms are. He's getting better, great. If he's getting worse, then you would get a scan just to see if you see edema in the bone around it, which is usually an indication that it hasn't taken. But you have to wait a year. It takes time. Yeah.
For arthroscopic labral tear repairs, what's the timeline for return to sports at your pre-injury performance?
Short answer is 4 to 6 months. That's usually when people are back to doing drills and skills and sports-specific activities, and then they pick it up from there, you know, according to how they feel. But it's 4 to 6 months. If they have a big impingement, it can take a little longer, especially if it's off the thigh bone. But generally 4 to 6 months, and I'm kind of releasing them to do what they want to do. It doesn't mean they're back to themselves, but they can usually start testing out the hip pretty well and figuring out what they can do and what they can't do.
How about for, you know, we show baseball players, I mean, what about that to get to your pre-condition, you know, where you got to a point where it's bad enough to have to get checked.
Right.
To get back to that level of performance right before that, you know, where you're performing at your highest peak or whatever.
Performing at your highest peak?
Yeah, I mean, you know, you showed A-Rod athletes and guys like that. I mean, when they to get them back, roughly a year, right?
I got a whole bunch to say about that.
Yeah, I know that.
They're not my patients.
Right.
Second, that's their job. Okay? It's a big difference when you're dealing with a high school athlete, college athlete, versus a professional athlete, versus somebody who has to get back to work because they have to support their family. All right? So there's all kinds of different levels to go back to. But at that professional level, you got to realize, first of all, it's their job to get better, or they don't get paid. Second, they have athletic trainers and massage therapists, everybody working on them every day, because otherwise the owners are paying for them to do nothing. And their career span, whereas everybody else that's working, your career is going to last from when you're in your 20s to when you're in your 60s. Their career span is probably about 5 years, maybe 10 for baseball, because half the time they're sitting on a butt. But that's why things are different with professional athletes. In addition to, you're dealing with different genetics. You know, these people heal faster. They do. They're in much better shape. They are much more in tune to their body and firing their core and protecting things around them. There's all kinds of different factors. But in general, it's about 4 to 6 months to get back to full sports. I mean, if you're not back by 6 months, then that means something's lagging.
In what sports do you see most hip injuries?
Soccer, ice hockey, football, lacrosse, ball gymnastics. I mean, everything. But probably, I would say soccer's probably, soccer and ice hockey are traditionally the highest frequency just because of the nature of the sports. And also, I think, because of a higher frequency of true groin injuries in those athletes, that's where we really started seeing it and recognizing it and like, well, what's going on here? This hip looks weird. All right, and that's where we really started picking this stuff out as to what was going on. But I mean, soccer, ice hockey, and football are probably the 3 top. Other questions?
Why the increase in the numbers? Is it because we're aware of it and we have a procedure to address it, or is it because there really are that many more injuries occurring in that area?
I think it's a little bit of everything. I think we are much more tuned into it, and we can recognize these problems that 20 years ago were blown off as, oh, it's a groin strain. He's not getting better, he's a malingerer. Oh, he doesn't want to play. You know, when truly they had a structural issue probably underlying what the problem was. So I think our recognition is probably number one. The radiological studies are so much better now than they were 20 years ago. You know, the frequency, again, we're more tuned into it, so we're gonna pick it up more. And you know, as far as the treatments, you know, our outcomes are so good with these procedures now that when people come in, they're more tuned into it too. Said, hey, I had these problems. I read this on the internet. This guy had this. I had this study. That's what I need. I'm like, okay, well, you don't need me. Go on the internet and fix your hip. With the procedures, the way we're doing them, the outcomes have gotten so much better. It's like if it's working, then we're recognizing that problem and we're more likely to treat it. You know, but then you have to go to the other side of it is when, you know, oh, the hip arthroscope, you have a shiny hammer, everything looks like a nail. You can't hit every nail because you might want to end up with some bent nails in your office, and that's not good. But I think it's all three of those things. That's why we're seeing them. Mostly because I think we were undereducated, and now we recognize it a lot better. Yeah.
If you suspect a labral tear, but it's not coming up on like an MRI, how often should you get reevaluated? You know?
Depends on the symptom. MRIs MRIs like the internet. It's a great and wonderful and awful thing at the same time because it can overcall things or it can undercall things. So if you have somebody who has symptoms consistent with possibly a labral tear, but the scans are showing up normal, MRI may miss subtle things, but usually it's not going to miss a big one. So it's not going to miss a big tear. First thing I would think is you start looking at other causes of the pain, like either dysplasia or instability or some impingement that may not have been picked up. Unlikely it's referred from the back or anywhere else, but you start looking for other causes of it. The hip flexor itself can be a primary pain generator that's much like a labral tear. And again, the same thing with that core muscle injury or sports hernia. Sorry, we'll whisper sports hernia. That can cause the same kind of symptoms. So there might be something else causing the problem, whereas the labrum is the thing people are most common cause of the problem, but it's not always it. And people are more tuned into that. But you tell them, oh, maybe it's dysplasia. What's that? So there may be another root cause for it. It might not be the labrum itself. And the labrum usually doesn't tear all on its own. There's usually a structural issue causing it.
But if like you haven't found a cause for it, like how often should you get reevaluated?
I mean, as often as you need. The hard part is if you keep coming in and getting the same symptoms, same treatment, it's not getting better. You know, that's tough. You gotta. I would say if you're not getting better, how often you need to come in? As often as you need to feel comfortable that you're doing everything you can to get yourself better. And you know, go to different places. People have different ideas on things. You know, like anybody in my field, every doctor is different, has a different skill set, and has a different good day or bad day. And you know, you want to make sure you're comfortable with your physician, and that they're listening to you, and that you're trying to pick apart your problem. Sometimes we can't find the problem, and that frustrates us because we want you guys to get better. We want you to be happy. And when we can't find the issue, then that's hard. But you got to keep, you know, you got to keep going back as much as you need to, and you know, just like good physical therapy places, some people are really tuned into the hip, some are tuned into the shoulder, and some are tuned into the knee. You want to make sure you're with the right person, make you feel comfortable. And if it's not getting better, start thinking about other stuff. Chiropractic work, acupuncture, massage therapy. I mean, if it's a muscular problem, they can really help. You gotta keep going around until you're better. Yes?
If the MRI shows like a small labral tear, how long does it usually take till it turns into like a big one, like a really big problem?
94 seconds. That you can't really answer because you don't know. Some labral tears, I see a lot of patients who come in and say, oh, my radiologist said I have a small labral tear. Well, the labrum isn't always firmly attached. Sometimes it's attached and there's a little sulcus under it, which just means a little space. And the dye goes in there and say, oh, that's a partial tear. And it's not really a tear. Or sometimes there's a small tear and it's actually bigger than it really looks. My key is not so much the size of it, but do your symptoms make sense with where that problem may be? So it's not so much the size of it. I'm sure huge and small, but if it's a small tear, the good news is likely it's not going to need to be treated surgically. You try everything else first, and the odds are you're going to get better.
She had a femoral osteotomy done, trying to fix her hip pain.
Oh, really?
Yeah, and we've been 3 years trying to, going around in circles, like you said, it's frustrating trying to find out what exactly is causing her pain, and
That's a completely different problem than femoral osteotomy.
Right,
It's a
well, that they
rotational
thought
issue,
that
yeah.
it was
They pushed off the
causing
labral
her
tear.
hip pain.
Right.
Because it was off, her leg was off center just slightly.
Right, right.
It wasn't.
Swing and a miss.
Yes, big one, very big one.
Yeah, I mean, unfortunately, usually small things don't cause big symptoms. and
That's
it
why they
can.
overlooked it, they said it's a small tear, it's not that, but, and then they kept on going, then they went to the FAI, we've been through every
Right.
possibility, and then this was the last thing that they
Still
tried with
left
the
it.
osteotomy, trying to, well, let's straighten her leg out and let's see if that'll stop the pulling on this muscle, and
Right, I still the same
that
symptoms.
wasn't it.
Not likely that that's solely it, but hard to really tell from here.
We need your card.
I figured that'd be a senior thing. Yeah, that's something we gotta pick apart in private. Anyone else?
All right,
All right.
we just wanted to thank Dr. Salvo and all the award recipients.